Everyone, good evening. My name is Gina Perrill, and it is my pleasure to welcome you to the Edward M. Kennedy Institute for the United States Senate. We are thrilled that you're here tonight. At the Institute, we are committed to engaging people in conversations about the essential role that each person plays in our democracy and in our society. And we do that through civic education programs that bring the United States Senate to life. And we do that by conversations like tonight that bring the issues of the day into focus. Senator Kennedy, the man for whom this organization is named, believed that a successful democracy depends on participation. He was a constant advocate for empowering people to take an active role in their communities. And in his decades and decades of public service, he was a champion of countless public causes, not the least of which was health and health care. So tonight on Columbia Point, we focus on public health in Massachusetts. And with so many pressing issues, we feel a collective urgency about tonight's program. There are many, many topics that could be top of mind: gun violence, access to care, vaccinations, mental health, and many more. And so we're fortunate to have a panel of experts and leaders engage with us in a complex conversation. Moderating tonight is Gideon Gill, managing editor of STAT, a news platform that examines health, medicine, and life sciences. His name might be familiar because he also previously served as the Boston Globe's health and science editor for a decade, among many, many other accomplishments. And joining Gideon tonight are Department of Public Health Commissioner Monica Burrell, Chancellor Michael Collins from the University of Massachusetts Medical School, Bowdoin Street Health Center Executive Director Philly Laptist, and Dean Linda Thompson from the College of Nursing and Health Sciences at the University of Massachusetts, Boston. We are enormously honored to have this group together. And so now I'll invite them to come up and take their seats on the stage in front of me. And I'll thank you once again, all of you, for coming here tonight and being at the Kennedy Institute. You are always, always welcome here. Thank you.
Thank you for that introduction. I want to, it is an honor for all of us, I think, to be here, given Senator Kennedy's leadership on the issue of public health, and I'm glad to see everyone here tonight. I just wanted to let you know we're going to have a discussion amongst ourselves for about 40 minutes and then open it up to Q&A after that, and then we'll finish up with some closing remarks by the panelists. So to my immediate left is Commissioner Monica Burrell. She serves as the Commonwealth's Chief Physician, having been appointed by Governor Baker in 2015 as Commissioner of Public Health. She's a board-certified physician who has practiced general internal medicine for more than 20 years and dedicated her career to reducing health disparities and developing data-driven solutions for keeping people healthy. As Commissioner, Dr. Burrell oversees a public health workforce of nearly 3,000 in an expansive department addressing issues ranging from environmental health to injury prevention to infectious diseases, and addressing public health priorities including the current vaping epidemic and the opioid crisis. Next to her is Chancellor Michael Collins. Dr. Collins is a physician who serves as Chancellor of the University of Massachusetts Medical School and Senior Vice President for the Health Sciences for the entire UMass system. He's held those roles for more than 13 years. UMass Medical School is ranked best in New England for primary care education by U.S. News and attracts more than $265 million in research funding each year. To his left is Philly Laptist. Philly is Executive Director of the Bowdoin Street Health Center. She's a second-generation Bowdoin, Geneva resident and graduated from Boston Latin School. Received her bachelor's degree in management and organizational communications from Emerson College and completed a master's degree in healthcare administration at Suffolk University. As a commissioner to the Board of Health for the City of Boston, public health is near and dear to her and is part of her personal commitment to her life's work. And all the way at the end is Linda Thompson. Dr. Thompson is Dean of the College of Nursing and Health Sciences and is a seasoned public policy and academic administrator, serving as the dean at 3 universities and cabinet-level official for a mayor and a governor. Dr. Thompson has spent the majority of her career promoting policies and programs to improve the quality of life for vulnerable populations of children and youth. She's published more than 100 articles, books, and abstracts, and secured over $50 million in sponsored grants and contracts. She earned both the BSN and MSN degrees at Wayne State University in Michigan and master's and doctoral degrees in public health from Johns Hopkins University in Maryland. So with that out of the way, you're all very accomplished. I wanted to start our discussion today with an issue that's been in the headlines today and for many months, which is vaping. So I want to start with you, Monica. So today, the governor's temporary ban on vaping was lifted, but Massachusetts has adopted restrictive rules on vaping and smoking, and I wondered if you could start by talking briefly about what those rules are, and also what this whole vaping episode tells us about what states can do to protect public health when the federal government fails to act.
Sure. First of all, I feel honored to be here with my fellow panelists and with you. Wonderful to be here in this space, honoring Senator Kennedy, and thank you all for being here today. So talking about vaping, it certainly is the issue of the moment, as this morning the Public Health Council met at the Department of Public Health. And for our audience, the Public Health Council is essentially like our board at the Department of Public Health. And I chair that board, and we review all regulations that come through the Department of Health. And what happened, just to take a step back in vaping, vaping or e-cigarette use really is relatively new as a health issue. The devices came on the market around 2007 and really entered a loophole in our nicotine devices in the United States and how they were regulated. And from there, what we began noticing from a public health point of view in the Department of Public Health a couple of years ago was a huge spike in youth use of these devices. So from our surveys and from talking to parents and kids, we learned that just here in Massachusetts, almost half of high school students had tried these devices, many of them not knowing that what they were taking in was nicotine. And these devices, really interestingly, take a liquid and heat it into a vapor, so into a gas, and then you inhale that, and once it goes back into the lungs, it becomes a liquid again. And many people were not really understanding, children I should say, that they were inhaling not mango flavor or Bubblicious, but actually nicotine and these potentially harmful chemicals. From that, we learned in August that there was new evolving evidence across the country that there was a lung disease associated with these devices that was hurting people and killing them. So we then in Massachusetts put in place a temporary ban on these agents, all nicotine and vaping agents, which you've probably read about in the paper, in order to start investigating these cases, learning more about them, and working with the CDC and FDA. That temporary ban, and I'm giving you the short version of this, that temporary ban, which was always meant to be temporary until we had in place legislative and regulatory mechanisms to regulate these devices, was lifted today because on November 27th, the governor signed a new law that modernized our tobacco control program to really keep up with this evolving issue. And today we passed regulations to really implement that law. And what they do is they restrict, really nation leading, restrict the use of these vaping and e-cigarette devices to, depending on what they are, the flavors can only be used in smoking bars, and the other devices are markedly restricted, and it gives us at the department more authority so that we can, one, require signage and information, and two, restrict where they're sold specifically to keep our youth away from these products.
How, the second part of my question is how difficult, or what is the challenge or the special challenge for Massachusetts to do this on its own when there aren't regulations at the federal level?
So as I mentioned, many of you may know that tobacco products in general, let's talk specifically about cigarettes, are regulated at the FDA level. And unfortunately, the potential regulation that could happen at the federal level around e-cigarettes and vaping products has not happened. So it has become an issue that really has been highlighted by these EVALI or lung diseases that states have gone and had to take action. So that's where we are, in a place where we don't know exactly what are in these e-cigarette and vaping devices. We know that over thousands of people across the U.S. have been impacted by this. You've probably heard about the death. We've had 3 deaths related to these devices here in Massachusetts. So this emerging public health crisis required our action to get ahead of it and try to prevent these illnesses and deaths.
Thanks. Phil, I want to ask you about, one of the issues when we all had a call before a few days ago, and one of the things we've spent a lot of time talking about is social determinants of health. And maybe, Phil, you could maybe start by talking about what social determinants of health are. But I'm also interested in how you at your health center in Dorchester, how that presents itself, what you see there and how it impacts, how issues of poverty and racism and crime and such are affecting the health of the people you see on a daily basis.
Sure. So with social determinants of health, when we define it at the health center, we look at things such as education, we look at environment, we look at public safety, access to food, all of those things which seem or can appear as if they are not tied to health are really barriers in some cases to our patients in terms of them being healthy. So, for example, we have about 12,000 patients that we serve at Bowdoin Street Health Center, and at least 10% of those patients are diabetic, and we have hundreds more that are pre-diabetic. And so, specifically for type 2 diabetes, many of us know that it can be prevented or delayed with healthy eating and exercise. So when we see our patients and they come in and we say either you're pre-diabetic or you are diabetic and you have to make some lifestyle changes, at the time, we now have America's Food Basket that's across the street from the health center, but at the time, we had many bodegas that were around in the community. And we can't expect that our patients would make changes if they don't have access to healthy food. The other message is if you exercise, even if you don't have a gym membership, get out and walk, or try to run if you can, or have children play outside, simple things. We can't expect that people will do that if they don't feel safe in their community. We do have many pediatric patients who are obese, and they too are experiencing signs of prediabetes and in some cases diabetes. And I can understand as a mother of 2 children that if I feel that outside is not safe, that they may be shot or maybe getting caught in crossfire, I'm not going to allow my child to go outside and play. Simple things like on the playground, there's drugs, there's lots of different things that get in the way of that. And I would prefer you to stay inside and play video games all day because I know you're safe there. So some of the ways in which we've addressed that in terms of food access, we realized quickly that many of the bodegas were not providing the freshest foods. And so we partnered with, at the time it was the Food Project, and we worked with them at a time when not many farmers markets were in the community. It was just a new thing at the time. So we actually started a farmer's market in our parking lot to make sure that ensure that not only our patients but the community had access to healthy food. Over time, we worked with some of the corner stores. We worked on healthy corner store initiatives to make sure that the healthier foods were to the front and not the 25-cent bag of chips, which are very enticing for anybody who will walk in and just want to grab a quick snack. And so with that, over time, right now, we've been able to create a healthy food prescription program where through grant funding, we're able to offer or incentivize our patients to with what we call Bowden Bucks. It's like Monopoly money, so they can actually purchase either frozen or fresh produce or fruit across the street at the American Food Basket. We've now downsized to, instead of a farmer's market, we now have a farm stand. And we also work with an organization called the Fresh Truck, which they actually refurbished an old school bus, and it's like a walk-on produce aisle of a grocery store. And then we also partner with another organization called the Daily Table. So we incentivize our patients. They have to see the nutritionist. We give them funds to test out healthy foods. So if you're working with somebody who has a limited amount of funds that they have to depend on food, so if let's say that their monthly stipend that they get from electronic benefits is $200, it is not the expectation that someone will say, oh, I'll try eating foods that I may not like or that may not last very long, and this is all I have for the month. So us incentivizing our patients is giving them an opportunity to try healthy foods. We have cooking classes. So we look at ways to encourage them. Other things that we do as it relates to some of the violence, we actually were designated as one of 5 neighborhoods that had a lot of incidences of violence in the community. So we were funded through the Boston Public Health Commission to do work on the VIP program. The acronym stands for Violence Intervention and Prevention, but in the community we refer to it as Village in Progress. So we work with community residents on issues that matter to them. So if a community resident says, I want to do a street cleanup on my street, then that's meaningful to you. We will help you to organize and get people to do that. If you want to have a block party, we'll help you to do that. So there's the VIP program, and then we are also one of the neighborhood trauma teams, and so we have a licensed clinician and also a family partner where we work with community residents who have been impacted by violence in their community. They don't have to be directly impacted as in the sense that their family member or relative. You could just be a neighbor that it was triggered, or you could come into the health center and be a patient already and have some sort of history of trauma, and we are able to connect you with a clinician who can see you and work with you through some of those challenges.
Thanks. Now, health equity is not just an urban issue in Massachusetts. It also is a challenge in rural areas. And in particular, I read a recent study that found that just 5% of medical school graduates are from rural areas. This is nationally, not just Massachusetts. And that means, and since providers tend to go back and practice in areas where they're familiar with, that means there's likely to be a continuing shortage of practitioners in rural areas in the U.S. And I wanted to ask you, Michael, about what UMass Medical is doing to try to address this problem here in Massachusetts.
Well, thank you, Gideon, very much, and thank you for coming this evening. It's a great privilege to be in the building that celebrates Senator Kennedy's legacy. We have a number of programs that we have initiated to assure that we're educating practitioners for all of the Commonwealth, not just for certain parts of the Commonwealth. One I would focus on is a newer program. It's called the PURCH program, P-U-R-C-H, the Program in Urban and Rural Community Health. That is, it's now in its 3rd year, established in partnership with the Bay State Health Center out in Springfield. We recognized that in the western part of the state, say from Sturbridge west to the New York border and up to the Vermont and south to the Connecticut border, that there were many communities out there, smaller communities, that didn't have a lot of practitioners and didn't have practitioners in certain very important specialties like pediatric dermatology. So we began a a program in partnership with Bay State, looking at attracting a group of medical students who would determine from day one, who would actually apply. So you can apply to UMass twice now. Let's call it UMass Regular and UMass Perch. But you actually make a commitment to look after a population from the very beginning days of medical school in partnership with the faculty in Springfield. So what does that mean? Well, what we're teaching our students, and I think that Philly made this point quite clearly, that when I was in medical school, we sort of learned that the genetic code was quite important. Today, the zip code may be more important. And so from the very first day of medical school, students, and I was just out there actually visiting with the students, the students are doing exactly what Philly mentioned. They are partnering with community-based entities. They recognize that being in the schools from a very early age, that if a child goes to school hungry and goes home from school hungry, they're not going to learn well. If they go home to a car because they're homeless rather than to a house, they won't study well. If they haven't eaten and they haven't slept, they definitely are not going to be able to do well in school the next day. They're probably not eating well. And if there's any challenges in the home with violence or in the neighborhood, and so the students very early on are interacting in both the schools and with the community agencies. It's causing us a very interesting problem. The students in Worcester are now saying, hey, we kind of like that program that's going on out in Springfield. We'd like to be able to have a similar population-based program. So too, at the other end of the spectrum with elderly patients. We recognize that there are many patients who are shut in their home. I'll tell you a story about a patient who had over 200 visits to the emergency. Actually, it was over 250 visits to the emergency room in a year. The woman was elderly, and she had congestive heart failure. And she would actually sit like this, watching TV. And as a result of that, and not taking her medicines, she would have very extensive peripheral edema, swelling of her legs. You notice a person has a big swelling legs. All that was required was a chair that was a lounger. And give that patient the chair, get the patient more horizontal during the course of the day. So if you notice, if you go to bed at night, you wake up in the morning, your ankles aren't quite so swollen. It's because it's easier to pump this way than it is to pump this way. And with good medicine management and this one, I'll call it a social intervention, the emergency room visits were down to less than 20 the following year. And if you teach that idea to a student in their first year, they're going to want to adopt that throughout their entire practice, that perhaps, maybe it always isn't a medicine or a biologic, but it could be an intervention that perhaps the patient needs most that might actually make them feel better.
And that reminds me, such a great example you're giving of thinking about how practices are changing. And I graduated medical school at Boston University in 1994, and one of the most valuable things I did in medical school was home visits. Because you would go, and in the clinic, in this very sterile, very formal environment, we'd say, take this pill and then do this and then go to this appointment. And you'd go into the home, and I remember vividly, we went to a woman and said, can you show us our medicines? She had a candy bowl, and then the different pills in it. We said, well, how did, and she had put all them in the thing, and she was, picking out which pills, the small white one, the large white one, and it really helped, right, to take care of her. If you look at the statistics and you say, how many people take the prescription that they're given in the office and actually fill it and take it as prescribed? Among all of us, it's just a little over 50%. So part of what we're, trying to figure out here, if you take a step back, is here we are in Massachusetts and in the United States. This is some of the stuff that Senator Kennedy spoke a lot about, with some of the most expensive care, actually the most expensive in the world. And yet when you look at the quality indicators, the standard things that we measure about disease control, we do pretty poorly as a country. So something is mismatched there, and we spend a lot of money on it. And if you thought that for the money that we spend, we have the healthiest people in the world, we might say that it's worth it. But this mismatch is kind of related to these things that we're talking about now, which is if you think any of us, you say, you know, what does health mean to you? It certainly doesn't mean coming to see one of us, right, in clinic. It's about being in your community and having robust connections to other people and having access to opportunity and having purpose in life. And as we think about that, and I hear these stories about, you know, teaching people early, it's so important that the medical community really has this sense of where the clinical interventions fit into someone's broader sense of health in their community. And at the Department of Health, we're really at this 35,000-foot view thinking about those connections, because there is a false divide between what we call public health and clinical medicine, because it's all a spectrum. And whether we're treating disease or thinking about how people can live healthy in their community, it's all connected. And some of this work is all about making those connections more clear. And when we're talking about equity and social determinants of health, unfortunately, there's a few of us who it's harder, and there are more obstacles, and the social needs are higher, and they are higher in every area. So part of the work that we collectively need to do, all of us together, and why I'm thrilled that you're here, is to think about how to make sure the opportunities we have are available to all of us.
Linda, I want to bring you into the conversation because I see you down there.
Sure.
Right.
Thank you. I want to take it upstream because what you've just heard a lot of conversation about are the social needs that people have and the individual things that could be done as a clinician or a practicing healthcare professional. But what we really need to focus more on is how do we create the type of policies and programs that can impact a total population instead of one individual. And so from a public health standpoint, we tend to think about the upstream type of strategies more at the societal level. Those social policies and health policies that will mitigate some of the things that you're hearing. And so one of the things that we're doing right now in our college is looking at how we can transform some of the schools right here in Boston so that kids are learning and we're involved and engaged in that. How do we begin to look at how health becomes a thought in any policy that's developed within any jurisdiction? And just one example, stop and frisk as a policy, what does that mean in terms of increasing a potential violent act against an individual and something happens to that person? Another example of an unintended consequence of a policy is a family living in public housing, and a grandkid brings some drugs in or gets involved in a drug crime, and the family is evicted from a housing project. Where's that person going to go? Those are policies that have been developed for another reason, but it has a health consequence to it. And so from a community-wide perspective, how should the community members, how should health professionals work with building coalitions around making sure that every policy that's formed within any jurisdiction thinks about the health connection to it as well? So I think we really don't think about it that well, but if we paid more attention to those upstream type of strategies, then we, at the service side, would not have as many problems. So that's one of the things I think is so critical, and how you in this room could influence anything that happens. And in a setting like this that named after Senator Kennedy, who developed the health policy workforce all over the country because of his engagement with having a person work for him and learn how to go back into their community to be a advocate and learn how to work with elected officials and policymakers to create these type of policies that I'm talking about.
Thanks, Linda. I want to shift a little bit to talk about mental health, which is, I don't need to say more, is just, a huge challenge for the Commonwealth, for the nation. In particular, one of the real challenges is access to quality care for mental health and behavioral health. And Monica, I wonder if you can just talk a little bit about Governor Baker's proposal that he made a few months ago to try to expand the availability of mental health care.
Sure. So, this is such a large topic, an important topic that you're raising. So if you think about mental health and then broadening it to talk about behavioral health, which to me is about addiction services and mental health services. So when you think about behavioral health, even having been in the medical system for so long, it mystifies me how we separate everything off and by taking somebody's head off. So the eye care, the dental care, the mental health issues, and the addiction needs are so separated from the rest of our physical needs, and to the detriment of all of us seeking those services. So we have a lot of work to do to improve those services. And as we are currently faced with the current opiate epidemic, which I hope many of you have heard about, really fueled by fentanyl, and still we lose about 2,000 individuals a year in Massachusetts die from this current opiate epidemic prematurely, and so we're doing a lot of work in that area. And as we look at those services, the Department of Public Health runs the Bureau of Substance Addiction Services. The way that the care is segmented out is really one of the key issues. And so, as an example, at the state level, we've been working with our colleagues at the Department of Mental Health to talk about ways to bring the care into a more collaborative model, including with our colleagues at Medicaid or Mass Health, so that we're looking across the spectrum and making sure, as pointed out earlier, that we don't have at the state level some unintended consequences based on policies that we've put in place. Related to the governor's health care bill, which you could find online if you want to see a summary of some of the key points in that, one of the areas I was so pleased to see included in that is a focus to have health systems refocus the way they do their care to increase the amount of behavioral health and primary care services that are provided, with a goal to increase that to 30%. And that's so important. Number one, as a primary care physician, I know that much of mental health services, addiction services can be provided in a primary care setting with the correct resources and training and access to services. And then the behavioral health piece is so important because none of what we need to do for medical care can be done without the behavioral health pieces. I remember vividly a patient of mine, I have it written down because it was so important for me. I was trying to take care of his diabetes and hypertension. As a primary care internal medicine doctor, he kind of put his hand forward and he said, "Doc, before I do any of this, I gotta get my mind straight. Can you help me with that?" And truth be told, it was much easier for me to get him his diabetes medicine and his high blood pressure medicine, and actually to see a world-class cardiologist, than it was for me to help get the services he needed for his mental health. So I'm really pleased to see this because it's the right thing to do, and the bill includes lots of pieces related to things that are obstacles for care, like having up-to-date directories of who's in your network related to insurance. I know many people have dealt with that, or being able to go to a mental health provider on the same day as your medical provider, and things like that, which we've heard a lot of complaints about. So that is in that bill, and one thing you can do is take a look at it and advocate for the pieces you feel are important in it to your elected officials as it goes to the legislature.
Michael and Linda, I wonder, like you both are involved with training practitioners, and how's that training, what are you doing to try to increase numbers of clinicians who are prepared to work with the mental health and substance abuse issues that their patients have? Particularly with opioids, I know there's been a lot of focus on trying to change, to try to improve the training that practitioners get?
Yes, well, we've actually been at the forefront in Massachusetts on this issue. The governor, very early on in his tenure, the first term, talked about the opioid crisis. He was quite moved by many patients and families that he met during the campaign trail. And so he brought the 4 medical schools together and said, you need to do more to educate the learners who are in school about this challenge. And the deans of the 4 medical schools came up with a set of competencies that each medical student, each learner should undertake while they were in medical school. And then that curriculum was implemented at each one of the medical schools. I'm proud to say that we were the first to do it. Might have had something to do with the fact that the governor was giving the commencement address that year, and I didn't want him to come and say, you didn't pay attention to what I asked you to do, so we did that. But it's a terrific program. I'll tell you a little vignette. When I was doing my training at St. Elizabeth's, you could hear a car come down Brighton Center and make the corner, and then come around the corner, and then come up the driveway, and then come up, and then you'd hear the doors open, and then you'd hear the doors shut, boom, boom, and the car would go back down the driveway, and in the driveway would be a person who looked dead. And you would grab that patient and put them on the gurney, bring them into the emergency room, and you'd immediately go through the protocol, and one of the things you gave was Narcan. And I can remember one time that the patient woke up immediately, just like Lazarus. Looks dead, administered the drug, wide awake. And 20 minutes later, wanted nothing to do with anything that we were doing for that patient. Ripped out the lines, told us where we could go, wanted to get out of the emergency room, would sign any piece of paper you put in front of them, but we knew that in another 20 minutes we were going to be in one big problem. That patient was going to be back in one big problem. Now, the first time I encountered that, it was when I heard this car coming around the corner. And now our students actually go through a series of simulated exercises with standardized patients, if you will. It's patients who are patient actors who actually may, in many instances, have had, sometimes the patient actor has had the problem, but we give them a series of protocols. They're not supposed to be free agents in this. They're supposed to stick to the protocol. But it now gives our learners the opportunity to experience, so first go through the protocol to deliver the medicines and experience what would happen once the patient has come through that, and then how they might deal with the challenges after it. And we have now 2,000 learners who have gone through that. So it's been our medical students, our nursing students, and those who are in graduate medical education training.
We use standardized patients. That model is probably pretty widespread use, but I wanted to shift the thought about how stigma sometimes keeps people from seeking mental health services. And so the approach that I like to use is that everyone at some point in time has a need for mental health, some kind of mental health, what I would call mental health need. And if we start thinking about it as a need just because you had a loss, you have a transition, you have something going on in your life, how do we minimize the stigma, educate the public, and get healthcare professionals to talk more about it as being something that so many people experience because it's a normal part of life. And one of the things that has been so concerning to a lot of universities around the United States is the increasing number of young people who are committing suicide and having these issues of having acute problems when they come to college, and the transition from high school to college. A lot of young people really don't manage that well. So doing mental health first aid training for a broad number of people is one strategy, but the idea of looking at how we as a society can shift the narrative around mental health challenges in a way that people will ask for help when they need it, that we pay more attention to people who are acting a little bit isolated, and we can talk about it in a way that makes people feel a little bit more comfortable to acknowledge that they're having a problem. But this is a really huge problem, and I know at the last university where I worked, we had 5 young people who committed suicide. You know, those are really traumatic for both students and faculty and the community around, surrounding and trying to figure out how we can, you know, do proactive things. Again, looking at ways that we can move more upstream, educating the public. There's a hotline or a number that you can call if you have a mental health problem, but really making sure that we talk about it in a way that will affect all of us at some point.
Philly, I wonder if you could talk about what at your health center, how you work with patients who have both physical and mental health issues and how that care is integrated.
Sure. So as I'm thinking back to what Linda just said, I remember, so I grew up in the community that I work in, and I sometimes think of that as both a blessing and a curse. So on our 3rd floor, we have behavioral health, and I remember running into someone I knew, and I said, "Hey, how you doing?" And he goes, "Well, how you think I'm doing? Look where I'm just coming out of." And I'm like, "Oh no." And so there is that stigma, there is that feeling of shame that people may not want to seek out help when they need it, even if it's long-term or short-term. So one of the ways in which we address that is we have integrated behavioral health. So I do think it's important to educate the practitioners who are in school so that they are in tune to it, but I think what's even more important is making sure that once they identify it, that they have the resources to be able to do a warm handoff and introduce that person to someone that they can actually talk to. So we have an integrated behavioral health social worker who is on call in the clinic. So when patients come in and they are seeing their PCP, if they talk about, you know, I'm not feeling well, or I've been depressed lately, and sometimes these things occur episodically. So it's like around the anniversary of the death of a loved one, or maybe just a rough period that they're going through for that moment in time. And so we do have a social worker that will come in, will you know, do an assessment, and we've seen that. We actually did a pilot when we started our behavioral health integration, and we noticed that the show rates for patients to come in to be seen in behavioral health were a lot higher if they had that intervention right at their visit, because, excuse me, they've met the person, they've talked with them, and either that individual can see them in an ongoing basis, or they can say, oh, I have someone else I would like you to meet, and do that warm handoff. So that's actually one of the ways in which we're able to do it. And one of the things that, you know, I mentioned that we have this trauma grant, and we're able to have a clinical social worker that goes out into the community and they visit with families who've had a recent loss. We notice that most times they are so in the moment of trying to understand what they're feeling and trying to process that incident that they don't want the help in that moment. So we have it set up so that we go back in 3-month, 6-month, 12-month intervals just to do check-ins and let them come to us when they're ready, but we don't want to lose touch, so we make sure we keep those lines of communication open.
Oh, yes, go ahead, Monica.
I just wanted to raise this point about stigma, which I'm so glad you're raising, because as we were starting our work to look at the current opiate epidemic, which I mentioned, and asking in community settings, how can we be helpful and what do people need, I was really struck by how much individuals spoke about stigma. And, you know, people would give examples and say, you know, my 17-year-old started using injection drugs, and, you know, I felt all alone. I didn't know where to get services. I didn't have a community around me. But if my same 17-year-old, you know, had a cancer and was getting chemotherapy, people would be over with casseroles and trying to provide support and help. And how it's so hard at a community level to admit that we have mental health issues or addiction issues, but also, unfortunately, those same biases, whether conscious or unconscious, continue throughout our health system, whether it's at the community level or in our healthcare settings. And so part of this work of becoming educated as community members, it's so important. You know, I always think when I come to a community discussion, and I'm not sure what fields you all are in, but you know, what can you do? Talking about it, whether it's suicide prevention, you know, we run through the Department of Public Health the suicide prevention hotlines, making sure you know them, whether you have addiction or mental health issues that you're comfortable sharing or in your communities advocating about. I mean, this example that the Chancellor gave of the medical schools coming together, this came from the students. We always think like maybe I don't have the power or the voice, but the medical students came to us and said, from all 4 schools together, collectively said, we don't think we have the training that we need to do what you're asking us to do. And that led to the deans coming on board and the governors coming on board. So just thinking about what each of us can do, because the stigma piece is so powerful, and that's why I always talk about the addictions as the medical disease that is the brain, so that we can help people normalize, you know, wanting to get help, and for those of us who are the clinicians and providers to normalize being there when people need that help.
Yeah, and I think in terms of what everyone can do, one of the things is just the language that we all use in talking about addiction and substance abuse. It's, you know, we don't refer to people as addicts. These are people who have an illness. They have, you know, just very small things like that can make a difference. So we're here to talk about, the title of tonight's program was The Next Frontier of Public Health. And I'm actually, it's striking to me that, you know, some of the issues that we're now dealing with in the public health and that you all deal with every day are old issues and that have come back. You know, so tobacco, for example, which we talked about at the beginning, has been with us for a long time, and we had made real progress. Youth smoking was down to under 10%. Now, you know, now we have, as you said, 50% of young people trying it. Another issue that is, you know, that we're dealing with is vaccines and vaccine hesitancy. And I guess I just wondered how, more broadly, how do you as people who work in public health view talking to the, you know, why these issues are arising again, what's the underlying problem, and how do you attack it? Linda, do you want to say something about that?
Sure. You know, we had a conversation earlier about this measles, measles outbreak, and how so many people, even with our science, and we know that immunizations work, why people who are educated and people who you would think would know better are not having their children vaccinated. And I'll just give an example. When I lived in Michigan, the area of the state that had the highest number of people choosing not to get their children vaccinated was in Ann Arbor, Michigan. One person who I was talking to about this was married to a physician, and so it was not that she was not educated, it was just that she believed that vaccines were going to cause harm to her child. This whole misinformation that happened around autism and how that might lead to the vaccine leading to a person getting autism. So the bottom line is, how do we ensure that we can have conversations about the science, and how do we have these debates that continue to pop up, but from a social and political standpoint, should we make decisions about about them being able to go to a public school or go to a school and expose people who have immune problems, and your decision is harming other people. But it is some of the things that are currently happening in terms of vaccines is really interesting in terms of downplaying science, and how do we turn that around. And I know states and cities are trying to do something about it, but I think the getting the public and community organizations to really take a stand and understanding how you, as citizens, can protect your family members, people with cancer, people who have problems that you don't want them to get exposed to something like that, that we have a cure for. But it is one of the things that's really pretty complex in trying to understand what is happening and why people are making these choices.
Yeah, Michael.
Let me make it personal for the audience. Okay, so we'll just go through a little exercise here. I'm not going to make anybody raise their hand, but you're going to think about it yourself. How many people here? Don't raise your hand. I'm not trying to embarrass you. How many people here have gotten a flu shot? Wait a minute, I'm not asking. No, I don't want you showing off if you got it. I just want you to know if you got it, congratulations. I'm proud that you got it. Okay, but how many people here got a flu shot? Now, if you didn't get the flu shot, where does the role of personal responsibility come into our healthcare system? 75,000 people in the United States of America died from the flu last year. 75,000 people. And if I started this little diatribe here by saying, if we knew that 75,000 people died every year from an illness and we knew a simple shot could prevent it, how many people would line up? Now, I'll make a prediction. And you can say, geez, I heard this guy at the Kennedy Institute. Darn, he was right. Wait till the commissioner and her people say that the flu is rampant in Massachusetts. And by the way, it's coming shortly, okay? We already have the first one. Wait till they say it. Wait till you see the lines at CVS. Wait till you see the lines at Walgreens. Wait till you see the lines at the doctor's offices. And the first time a child dies in Massachusetts, wait till you see the lines at the pediatricians. I can't tell you how many people tell me, I don't get a flu shot because when I got the flu shot, I get the flu. Well, let me tell you something, okay? It is impossible for you to get the flu from the flu shot. So the next time you say that, you're acting not too smart. Now, you all know what I'm talking about. The point I'm trying to make, and I thought this is maybe where you're going to go. So if we think about this into the future, if we think about the public health, oftentimes we think, it's kind of everybody else. It's government's role or it's the practitioner's role. There is a personal role. And what we eat and what we drink and when we have care, whether we access that care and whether we do the preventive measures that we know we should take is very important to preserving the public health. And I really want to applaud the commissioner and her staff for this because they've done a terrific job in making people aware that it is important to receive vaccines. It's important for children to be vaccinated. There is this thing called herd immunity, which means if almost everybody gets the shot, it's very difficult for the other people to get it. But you hear about these schools where maybe 80 students in a class in that particular school have not gotten a vaccination. That's going to make disease much more prevalent in that school. And so it's important for all of us to take important. We can argue about 5 people who say, under no circumstances I'm getting it for this religious reason or that personal reason, whatever it is. We can do that, but that's not really, it's an issue. I'm not going to say it's not an issue. But the bigger issue is that those of us who can, should.
Thank you, Michael. So it's time to open it up to your questions. So that we have people with microphones, and if you would raise your hand, I will recognize you. So don't be bashful. Okay, right here, yes.
A comment and a question. I'm sorry. A comment and a question. The comment is for Mr. Gill. Staff does a great job.
Oh, well, thank you very much.
I appreciate what you do, and I'd strongly suggest the Globe take it from where it usually shows up on the business page and put it on the front page and move some of that sports that shouldn't be on the front page into the sports page. That'd be a great help. Please pass that on.
I will, thank
I'd be
you.
glad to give a name and an email address. The second is a question for the Commissioner. To the point of rural health, what is the Commonwealth doing by way of outreach on health issues, the prevalence of hospitals and doctors out in the rural part of the state? And also, is there any effort to address what I think is a more complicated health insurance issue out in the western part of the state than we have here in the east, along with what Dr. Collins spoke about in that program? Thanks.
Thank you for being here. So at the Department of Public Health, we have an Office of Local and Regional Health, and part of that is a focus on rural health. So we actually have a group that is focused on rural health, which of course in Massachusetts is mostly in the western parts, although the islands as well. And they are engaged with local communities and health around specific issues related to rural health. So they, that includes things such as access to healthcare, access to health providers, access to health services, as well as other issues that are specific to rural health. So we do have a group focused on that, and as part of our equity work, we look at our issues and map them out across the state. So depending on what the illness is or the issue, you can look at maps of Massachusetts and find that. There's a tool, actually it's a new tool that we have available through the Department of Public Health called the Public Health Information Tool, or FIT. You can Google it and find it, and you can look at multiple different data and health points, and then go to specific towns or cities across Massachusetts to see how it affects those areas and compare it to others. And we have had communities use that for their community-based work, including in rural parts of our state. Our hope is to provide these data sources in a public-facing way so that those individuals who are in those areas can use them to specifically understand health and health risks and the determinants of that in their areas.
Great, thanks. Other question? Yeah, in the back there.
Dr. Thompson, it seems like we have a shortage of healthcare professionals, even in the Commonwealth of Massachusetts. What are your school and other agencies doing to encourage students to consider a career in healthcare? And I guess part of it is not everybody needs to go to medical school and become a doctor. You know, there's a lot of care that happens at various levels. So how can we get more students interested in becoming health practitioners so that that really can expand the care in lots of neighborhoods?
Sure. Thank you for that question. We, just to give you a little bit of information about our college, we have over 2,000 students in our college who are interested in entering a health profession, people interested in becoming nurses, people interested in getting a graduate degree to become a nurse practitioner, people interested in becoming physical therapists, occupational therapists, and exercise scientists and exercise physiologists. So there is a huge interest in people wanting to come to our college. One of the things that we are looking at doing is expanding our number of students that we admit and putting for example, our second degree program online. So the theory part would be online, and the hands-on would be face-to-face just to increase access in that way. The other thing that our students are involved with right now is working to increase physical activity in public schools. So our students are at the school, and people who are there see them. These are elementary schools, middle schools, so that they can have an aspiration to have an interest in coming into our college. And creating those pipelines are really important in order to get people thinking about a career as a nurse or a nutritionist or a different type of health professional. So we're actively involved in the community, getting people to understand that there are other options as well. Thank you.
Yeah, all the way in the back there.
Hello. Something I noticed that wasn't quite touched upon when it came to a public health crisis was the growing numbers of dementia diagnoses moving forward in this country. My question is actually for Philomene. Something that we see quite frequently is disparities amongst diagnoses excuse me, particularly when it comes to African American communities in the United States. So my question for you is, how does your community handle that, and how do you see a better approach to engaging those families and caregivers that are currently dealing with that?
Thank you for your question. So one of the things that I didn't talk about in terms of how we engage our patients is when we look at the barriers, and so when we look at the barriers in terms of, you know, why people aren't accessing care, we have community health workers that will go into the home and can actually do an assessment. But if I take it a step back to being in the exam room with the PCP and doing that integrated behavioral health intervention, those are things that I think one of the issues that we are having is having people coming in often enough to be able to make that determination, to be able to make that diagnosis. And one of the other issues is how do you engage family members to do that holistic care, to be able to support family members who may have been diagnosed or who are not diagnosed but they know something is wrong. How do they get involved and engaged in the care? So a big part of that for us is our community health workers and how they work with families, how they work with individuals. When we sense that there's a problem, they can actually do a deeper dive and help us engage the patient more and building that trust, and we're better able to do that. But then I also see the other component of it is where culturally, sometimes those things are known and they kind of chalk it up to just old age and it goes untreated. You know, speaking from like my dad, he had dementia, and my mom would often say, oh, he knows what he's doing. Or he would like not take the pill because he felt like it made him feel a certain way and he didn't like how he felt. So it is challenging all around on both the family side and on the patient side, understanding that change is happening to them, but still wanting to live somewhat of a normal life. So the community health workers engaging, you know, other supports, because family members can't always be at home to provide additional care. It's something that is definitely on the rise and that we're noticing more and people are paying attention to and trying to figure out like what's the best way to address it. We actually don't have like a standard or a best practice that we use, but we just try to get in the home and see what works best for the patient, or try to do that in the visit as best we can.
Okay, right here.
Hi. First, thanks so much for this conversation. It's just great. I've been out of the state for 15 years, and it's nice to hear this public health conversation back again. I'm curious, a number of you have talked about advocacy and the role that you can play as an advocate. And I'm curious if you can each maybe share a little bit about the different resources or organizations that are involved in, that people can get engaged with to become actively engaged in advocating for those issues they care about.
I'll just be brief and say, thank you for being here today. You know, vote. Elected officials like to hear from constituents. Wherever you are, whatever the issue is you care about, make sure they hear your voice. It's really important. It helps us. Not as many people are educated in public health as should be. And if you are helping our elected officials understand the relevance of issues, that's extremely helpful. And wherever we sit, whatever our jobs are, community positions, advocate and use the levers that you have, because we all have levers that we can pull to improve public health.
I would say that it's fair. I would not minimize the power of each person's voice. I mean, you saw how one vote could decide an election in Boston this week. I can tell you, if 3 people call a member's office with an issue, it's important. If 10 people call, it's a crisis. And I would emphasize the importance of individual advocacy. Now, many people find that a particular disease interests them because it's affected the family, whether it's dementia or breast cancer or cancer in general, and there are many disease organizations that do a terrific job of advocacy, and sometimes it feels a little more comforting to be part of a group. But I would certainly emphasize the individual's voice is very important.
Just echoing with both Dr. Burrell and Dr. Collins has said is the same thing, you know, advocacy and having your voice matter. I also think that just organizing within your own networks, making sure that people are aware of the issues, and I find that oftentimes people just don't know if they're not involved or engaged. So I think that's one part of it, and as Dr. Burrell talked about, you know, making sure that your elected officials know what's happening. If you're a part of a civic group, and make sure that they come out, that they listen and they hear real life stories and its impact on what it's having, if you can get those, but more importantly, making sure that you educate people about some of the issues around public health.
Just, you know, there's a movement in the public health community, and we're talking about Public Health 3.0. And as a function of that transition and how we're trying to educate healthcare professionals, the idea is for health professionals to become more strategists, and as that role is to begin to work more deliberately with communities and teach health professionals more about the systems and how you really engage with community-based organizations or groups to get them knowledgeable and the type of influence that they will have if they understand data, if they understand how to turn those data points into a strategy, and then how to go and advocate for that. And when I worked for the governor of Maryland, I was able, during an election year, got Head Start parents. I taught them how to become advocates, and they were able to get funding support for Head Start centers all over the state because they were taught that the strategy to do this is in this election year you could influence, because there were large numbers of people who had children in Head Start centers all over the state. They showed up in busloads. I think everyone in this room has issues that you care about, and what you have to think about is how do you bring together 10 people, 20 people, and go and share your idea about what needs to happen, who they're going to pay for it, who's going to benefit from it, and you have to have your voice.
So unfortunately, we are out of time for questions, but I get the last question. So I just want to ask each of the panelists for some closing thoughts and anything you want to bring up that we haven't discussed, and also just since we are here to talk about the next frontier, is there something that you're looking at that maybe is not yet like a huge issue, like right in front of us? And I know a lot of things just pop up, like vaping, but what are you looking at down the road to be an important public health issue we need to be aware of? You want to start? Yeah, Mark.
So some of you may be aware that Massachusetts is one of the healthiest states in the nation. Last year we were ranked second, just after Hawaii. So I tell you that because that's not by accident. Massachusetts is one of the healthiest states in the nation because of our collective work and our collective community-based and individual work where we demand health for ourselves and our loved ones in our community. And it's about really smart health policy. It's based on education and advocacy, and it's about access to world-class healthcare systems in the communities and in the tertiary care level. And that's how we got to be the second healthiest place. And so what I see as our work in public health now, public health is defined in lots of different ways. One of my favorite definitions is what we do as a society to ensure that we all have access to health opportunities. And as you think about that, to me, our work ahead or the next frontier is to think about that. To me personally, it's about social justice. It's about thinking about health as not a privilege for some, but a right for all. And I see our work collectively together to make sure that everybody in Massachusetts has access to that number 2 standing, and that we all have opportunities for health, and that how do we think about us doing that together, as we are focusing on that at the Department of Public Health, is using the data that we have to understand where these persistent data disparities in health inequities are, and targeting our work to those areas. So I hope you'll join us in that work.
Thank you, Monica. Michael?
So I think one of the big opportunities in the future is what's being called today artificial intelligence. But if you think about this for a moment, there'll be a time in the near future when just by doing this, we'll know your temperature, your blood pressure, your heart rate, perhaps your blood sugar. And before you put the phone back in your holster or in your pocket, that information will go directly to your medical record. That is happening. You can today, right now, if you have atrial fibrillation and you have the UMass app, you can go like this and you can send us a tweet. You feel a little flutter right now, like I'm feeling when you say not everybody should go to medical school. That makes me nervous. You can go just like this, and in 20 seconds you can send your heart rate to your medical record. Now, the opportunity, we're here talking about some who don't have, most everybody in the world has a phone, so we'll get to a point where that could happen. But, you know, it could be a simple thing as glasses. You just put your glasses on, and you just push the stem at the end of it, and we'll know your temperature and your heart rate, all those things. What's the point? The point is, we may be educating a whole new group, to your point, a whole new group of healthcare practitioners. We'll call them health data analysts. Don't call it you call it what you'd like. But you think of the amount of information that we'll have and how it will be, how we will know where illness exists in a city and where some of the challenges are and where patients are ill. And we will be able to actually promote the public health, if you will, by dealing with those issues before they become a big problem. Just imagine if every time you went to the bathroom, we knew your weight, and you have congestive heart failure, and your weight is up 10 pounds today over yesterday. We know right then we need to send someone to the house to give you your increased diuretics so we can help you to deal with that. Now, the last point I'd like to make, I just want to tell a 1-minute story if I could. I'll never forget on Martin Luther King weekend in the late 90s, I got a phone call from Barbara Suliotis. Barbara Suliotis is a member of the Institute board, but she was Senator Kennedy's principal deputy. And she told me the senator wanted me at a meeting at 8 o'clock on Monday morning at Children's Hospital. And when you got that phone call, it didn't make any difference where you were or what you do when you showed up at 8 o'clock on Monday morning. And all of the CEOs of the big healthcare systems showed up. And the senator had an issue. And the senator's issue was that he didn't believe that the leaders of healthcare were doing enough to ensure that everyone had coverage. And I will never forget that meeting, how it was very nice. He came in, Michael, nice to see you, nice to see you, then he said, and we got it good. And the message was that we needed to speak to our colleagues around the country to get their senators to participate in this issue, that it couldn't just be a few senators in New York and Massachusetts and Illinois, that it really needed to be an issue across the nation. And I think of that, the power of, to your point, the power of advocacy and the power of leadership. And clearly, Senator Kennedy, for 47 years, I believe it was the voice of healthcare in America. And now, to further his legacy, it's important that we lever our voice for healthcare for the nation.
Thank you.
So you started off the questions with asking me about social determinants of health and to speak on that. And one thing I will say about that is the issues around the social determinants of health are systemic. And we've been talking about advocacy. We've been talking about everyone in this room has an ability to make a change by voting, by educating. One of the things that I foresee on a community health level that I'm seeing more and more and hearing more about is displacement and gentrification happening in our communities. Our patients are coming in, they are worried, they are scared. They can access our help by just walking to our health center now. But the further and further they become more and more displaced, they get worried about who will care for me, who will understand me, who will speak my language, who who is going to help me with all of these other things that are impacting or creating barriers around my health? So I encourage all of you to be that voice, and to, when we think about social determinants of health, really think broadly beyond just the health aspects. And the last thing I'll say is one of the ways in which we've been addressing it is creating a lot of partnerships and collaborations. I think that's how we've seen our most successful work. I gave examples about that and what we do in terms of food access and violence intervention. So if you work for an agency and you have the opportunity to partner with a community-based organization or a community health center, please advocate and support that as best you can.
Linda, you got the last word.
Sure. So, we've talked a lot about that many of the things that cause problems in the health with individuals' health has nothing to do with the healthcare system. It has to do with more societal and social issues. The rankings for the country just came out on Friday, and Massachusetts still is number 2 behind Vermont. But the challenge in our Commonwealth is that there's a gap in the health in the health status of people based on educational level, and so that says that that there still are problems, and that we need to pay more attention to how do we reach people who are less educated, or how do we ensure that people get the education that they need in order to take care of themselves. So I think from a social and health policy standpoint, we all have a role to play in how we talk to local officials, state officials, federal officials, and ensuring that we don't leave people behind. Because if you leave people behind, then you will have those disparities, those health disparities, and some people won't live as long as other people just because of the zip code that they live in, the skin color that they have, the educational level that they have, and so we as a society need to pay more attention to that.
Thank you. And so I just want to thank our panel, Monica and Michael and Philly and Linda. I want to thank all of you for coming out tonight, and I want to thank the Kennedy Institute for hosting this event. So that's it.